I'm Silvia Gabriela Scintee. I'm a public health and health services management specialist. I work as Deputy General Director for the National Institute of Health Services Management in Bucharest, Romania. I have almost 30 years experience in the field of public health and health services management, and I'm happy to be with you today.
Okay, thank you. And so for the first question, to begin, could you give us a brief overview of the current global COVID-19 burden? How has the situation evolved compared to the early phases of the pandemic?
Well, even if WHO declared the public health emergency caused by COVID-19 ended in May 2023, it's still monitoring the COVID-19 epidemiological situation via the WHO COVID-19 dashboard, as this continues to be a significant public health concern with global circulation of the SARS-CoV-2 virus and hospitalizations and deaths continuing to occur. Nearly 780 million cases and more than 7.1 million deaths due to COVID-19 have been reported worldwide since December 2019, but the actual number is thought to be higher due to underreporting. In the 28-day period from 10 November to 7 December 2025, there were reported almost 60,000 confirmed new cases by 87 countries, which is a decrease compared to the 100,000 new cases reported from 92 countries in the previous 28-day period. However, 19 countries from Africa, the Americas, and Europe showed an increase in new cases of over 10%. Over the same 28-day period, a total of 5,322 hospitalizations were reported from 32 countries, and 894 new deaths were reported by 37 countries. These countries from Europe showed an increase in new deaths of over 10%. In November 2025, 91 of reported deaths with age information occurred in the population age 65 and over. This situation is anyway underrated, as many countries ceased reporting COVID-19 surveillance data to WHO or have integrated the COVID-19 surveys into existing respiratory disease surveillance. According to the last COVID-19 global risk assessment made by WHO in September 2025, the global public health risk from COVID-19 has changed from high to moderate in mid-2025, with declining deaths and hospitalizations since 2022. This is due to the increased population immunity, improved clinical management of the disease, and low virulence of the circulating variants. However, this statement should be treated with caution, as the limited reporting undermines accurate risk assessment. In addition, keeping in mind that the virus continues to circulate widely, and even if there are available effective vaccines against severe disease, the global vaccine uptake among high-risk groups was low in 2024, raising concerns amid continued virus evolution. So the COVID-19 situations require continued vigilance.
Okay, thank you. And which populations remain the most vulnerable today and why? Has the profile of at-risk groups changed over time?
At-risk groups are determined not only by the individual and social characteristics that make people more vulnerable to negative outcomes, but also by viral characteristics and health system response. In early pandemic, the circulating variants were producing more severe diseases in patients with no immunity. By the time the vaccine was available, people got immunized from prior infections. And also the current circulating strain, even if more contagious, is less severe in general than previous variants, according to the CDC and WHO. This leads to a high number of people infected, but the vast majority will either be asymptomatic or experience a cold so mild that some might well mistake it for a seasonal allergy, and not taking the protection measures would infect others. There is a higher risk of spreading the disease, and even if the current strain is less severe, there are still particularly vulnerable people with a high risk of developing a severe disease. Old age remains one of the strongest risk factors for severe COVID-19 outcomes. Some scientists consider people over 60. Others claim that today you are at severe risk only after 75. At risk are also patients with certain medical conditions, such as lung conditions or heart conditions, diabetes, obesity, kidney or liver chronic diseases, weakened immune systems, as in patients with cancer, HIV, organ transplant, or taking certain medications, blood disorder, neurological conditions. Additionally, being unvaccinated or not being up to date with COVID-19 vaccinations may also increase the risk of severe COVID-19 outcomes. Vaccines and prior infections made many less likely to get severely ill. Anyhow, better antivirals today reduce severe disease for high-risk individuals, changing the outcome. Despite this, experts have advised that all vulnerable groups should get at least the latest COVID-19 vaccine, which can provide vital protection against serious illness, hospitalization, and deaths, and warn that there is no guarantee that more severe variants won't emerge in the future. It means the threat posed by COVID-19 is far from over, and the virus should not be underestimated. Experts expect it to continue being a significant and persistent threat to public health.
Okay, thank you very much. And from your experience, are there notable regional differences in how COVID-19 continues to affect high-risk groups and the broader community?
As I said earlier, WHO monitors continuously a set of indicators related to COVID-19 infection, hospitalization, and mortality. Unfortunately, not all the countries are reporting, which makes it difficult to notice the regional differences. The last WHO risk assessment report from September 2025 mentions only 55 member states reporting on test positivity over the week ending 29 of June. These are concentrated in just 3 regions, 26 out of 53 countries existing in the European region, 18 out of 35 countries in the Americas, 10 out of 21 in Eastern Mediterranean region, and only 1 out of 27 in the West Pacific region. There is an overall decline in reported deaths, but since this coincides with a reduction in the number of reporting countries, the interpretation of global trends is limited due to decreased geographic and income level representativeness. As a result, it is difficult to determine with certainty whether the observed decline reflects a true decrease in global level or it happens only in the reporting countries. However, since mortality could be related to the population level immunity due to infections and vaccination, strong variations in vaccine uptake observed in 2024 across regions and income strata in all population groups might suggest differences in mortality. Across all groups, the vaccine uptake in older adults was greater in the West Pacific with 38.6%, European 60%, and Americas 30% than in other regions. Similarly, in health and care workers, uptake vaccine was higher in Americas with 50%, West Pacific almost 5%, and European region almost 4%, than in other regions. Generally, the African, Eastern Mediterranean, and Southeast Asian regions featured lower vaccine coverage levels than the other regions, making their populations more vulnerable. Across income groups, trends varied by population group. In older adults, high-income and low-income countries had the greatest vaccine uptake rates, 21 and respectively 14%, as compared with 6.8% in upper middle income countries and almost 5% in low middle income countries. In healthcare workers, upper middle income countries and health income countries featured the greatest vaccine uptake rates with 10.5 respectively 5%, reported as having received a dose during the year, as compared with only 2% in low-income countries and 0.3% in lower middle-income countries. Anyhow, the regional differences might be given by the differences in the determining factors of the disease and in the characteristics that put the population at risk, namely high percentage of elderly, crowd places, low economic development areas, less capacity of health systems in coping with the prevention, testing, monitoring, and or treatment of the disease.
Okay, thank you. And what are the main factors that keep certain groups at higher risk, biological, social, economic, or related to access to care?
We might say there are two main types of COVID-19 vulnerability factors. Individual factors represented by frailty in the old age, chronic diseases, including obesity and alcoholism, weakened immune systems, pregnancy, or any biological or behavioral factor that makes the human body more susceptible of getting a severe disease. And social factors that include low income, poor education, overcrowded houses, poor hygiene, race, ethnicity. The research found that social vulnerabilities reinforce individual vulnerabilities, creating a vicious circle. As well, certain groups have reinforced vulnerability by more factors. For example, it's more likely for certain ethnic groups to have poor education, low income, to live in a crowded area, and to have an unsupervised chronic condition. Besides these two main groups of vulnerability factors, health system factors also affecting some population groups, putting them at higher risk. They consist of different barriers to accessing healthcare, from lack of health insurance or lack of services provision in certain areas to high cost sharing, poor physical access, discrimination, or mistrust. Lack of integrated and affordable health services are affecting the population at risk through poor vaccination uptake, poor testing and monitoring of infected cases, inadequate COVID-19 treatment, and also inadequate treatment of other diseases that makes the individual vulnerable to the infection. Particularly vulnerable are also the population in the regions with violent conflicts and wars, with disruption of healthcare services, and displaced population located in overcrowded places and with no financial resources to access proper healthcare.
Thank you very much, Silvia, for all your insights. It's been really valuable and great as well. And with that, I thank everyone for watching the part 1 of our episode, and I invite you to watch part 2 that is available on our YouTube channel. Thank you.